Right, let's dive in. Imagine this. A sudden, really sharp pain, somewhere you definitely don't want it. Today, we're tackling testicular torsion. It's a serious urological emergency where, honestly, every single minute counts.
Absolutely. It's critical.
We're going to break down what it is, why it happens, the sort of red flags you need to look out for, and crucially, what needs to happen fast. Think of this as your high-yield guide really getting to grips with this condition.
Yeah, exactly. Our aim here is to take all that key info on testicular torsion and just lay it out so it's easy to grasp and hopefully easy to remember. Whether you're, revising for exams or just want to be informed about something pretty important, this deep dive should cover the essentials.
And we keep saying every minute counts because it genuinely does.
Yeah.
Spotting this quickly, that can be the difference between saving a testicle and, well, not.
It really is that stark.
So let's get straight into it. What exactly is testicular torsion?
Okay, so basically, testicular torsion is when the spermatic cord, that's the structure that supplies blood to the testicle, it twists around itself. Think of like kicking a garden hose. The water stops flowing.
Right.
Same idea here. The twist cuts off the blood supply. The testicle doesn't get enough oxygen, and that leads to ischemia.
It's a major urological emergency. We see it most often in males between 10 and 30 years old, but the real peak is around those teenage years, maybe 13 to 15.
Okay.
A little memory aid we sometimes use is twisting cord, blood flow, ignored. Helps picture the core issue.
Twisting cord, blood flow ignored. Got it. So what causes this twisting? What's the etiology?
Well, interestingly, a lot of the time it just happens spontaneously with no clear reason.
Really, out of the blue?
Yeah, seemingly, like that sudden knot just appearing. But there are underlying anatomical things that can make it more likely. One common one is a high attachment of the tunica vaginalis, that's the membrane surrounding the testicle. If it attaches higher up than usual, the testicle can swing more freely inside the scrotum.
Ah, like a bell clapper. Exactly. That's the bell clapper deformity. It gives it more potential to twist.
Yeah.
Also, though it's less common, sometimes physical trauma or even just really strenuous activity can sort of nudge it into twisting.
Okay. So who are we most concerned about? Who's most at risk here?
Age is definitely a big factor. We see it in two main groups. Newborns, which is called prenatal torsion, and then that adolescent peak we mentioned.
Right.
Also, if someone's had torsion before, even if it resolved, they're at higher risk of it happening again.
Makes sense.
And those anatomical issues, like the bell clapper thing, obviously increase risk. There might also be a family link. Sometimes you see it run in families, suggesting a possible genetic predisposition.
So let's trace that pathophysiology again. The cord twists.
Right. The twist puts pressure on the blood vessels inside the cord, squeezes them shut.
Like stepping on the hose.
Exactly. So blood flow out gets blocked. First, the veins are easier to compress. Then the blood flow in through the arteries gets cut off. No oxygen gets to the testicular tissue. That's ischemia. And if it goes on too long, the tissue starts to die. Irreversible damage.
Okay.
So again, twist, squeeze, no breeze for the testes.
Yeah.
It emphasizes that lack of oxygen.
Got it. Now, sudden, severe pain down there. It could be other things too, couldn't it? What else is on the differential diagnosis list?
Oh, definitely. And distinguishing is crucial. Probably the most common mimic is epididymitis.
Which is?
Inflammation of the epididymis, that coiled tube at the back of the testicle where sperm matures. It causes pain and swelling too. But epididymitis usually affects slightly older men, and when you examine them, the tenderness is often localized right over the epididymis itself, and they might have signs of infection, like urinary symptoms.
But what else?
Testicular trauma, obviously. If there's a clear history of getting hit or injured there, then there's torsion of something smaller, the appendix testis, or appendix epididymis. These are tiny bits of leftover embryonic tissue on the testicle or epididymis.
And they can twist too.
Yeah, they can. It causes pain, often quite localized, maybe like a blue dot sign visible through the skin sometimes. It's more common in younger boys, say 7 to 12.
Right.
An inguinal hernia pushing down into the scrotum can cause swelling, maybe discomfort, but you can usually feel the hernia going up into the groin.
Any other possibilities? Maybe less common ones?
Well, you might think about a testicular tumor, but that usually causes a slower, often painless enlargement. Sudden pain is rare. A hydrocele, that's fluid collection around the testicle, is usually painless swelling, and it transilluminates, meaning light shines through it. Torsion doesn't.
Okay.
and very rarely mumps or orchitis inflammation for the mumps virus.
Yeah.
But that's uncommon before puberty, and you'd usually have the classic swollen salivary glands too.
So the key with torsion seems to be that sudden, severe onset.
Absolutely, that's the main differentiator.
How common is this? What do the numbers look like, say, in the UK and US?
The overall incidence is estimated at about 1 in 4,000 males under 25. Pretty consistent across the UK and US.
So not incredibly common, but significant.
Definitely significant, especially given the consequences of delay. That peak age is really between 13 and 16. Some UK data from England a few years back showed over 3,000 cases in a year, and most of those were in children.
Wow.
And interestingly, trauma only accounts for a small fraction, maybe 4 to 8% of cases. What's also important is that some patients report having had similar severe episodes of scrotal pain before, which then just went away on their own.
Ah, like it twisted and then untwisted itself?
Exactly.
Hmm.
That suggests intermittent torsion to torsion, and it's a big warning sign.
Okay, let's talk clinical features. What are the absolute classic signs and symptoms, the things that should make you immediately think torsion?
Number 1, sudden severe unilateral testicular pain. It can be excruciating, often radiates up into the lower abdomen or groin. The affected side of the scrotum usually becomes swollen, red, and very tender. Nausea and vomiting are really common too because the pain is so intense. And then the big physical sign, absence of the cremasteric reflex on that side.
Remind us about that one.
You gently stroke the skin on the upper inner thigh. Normally, the cremasteric nerve causes the cremaster muscle to contract, pulling the testicle upward slightly on that same side.
Okay.
In torsion, that reflex pathway is often interrupted. So no upward movement. It's a very sensitive sign, though not 100% specific.
So memory aid for features.
How about severe pain, swollen and red, for reflex fled? It's the key points.
Severe pain, swollen and red, reflex fled.
Yeah.
Okay, memorable. What else might you find on examination?
Well, the testicle itself is usually extremely tender to touch. It might also feel like it's sitting higher up in the scrotum than the unaffected one, kind of pulled upwards by the twisted cord. And it might be lying horizontally instead of vertically. That's the bell clapper lie. Again, the scrotal skin itself can look red, maybe a bit thickened or edematous. And there's preem sign. If you gently lift the affected testicle, the pain typically gets worse in torsion. In epididymitis, elevation sometimes actually relieves the pain a bit.
That's a useful distinction.
It can be, yeah. But the bottom line is, any male, especially under 25, presenting with acute, painful scrotal swelling, you have to suspect torsion first.
What about the history? What might the patient tell you?
The story is often quite traumatic. Pain starting very abruptly, maybe even waking them from sleep. Sometimes it starts during physical activity, but often not. And definitely ask about any previous similar episodes, even if brief. That history of intermittent severe pain is highly suggestive of intermittent torsion.
And if the pain seems to have eased off a bit by the time you see them?
You still need to be very suspicious. Unfortunately, sometimes the pain can lessen if the testicle is already infarcted, meaning the tissue has died. So easing pain isn't necessarily reassuring.
Wow, okay. Anything else on examination, particularly early on or in specific cases?
Yes. Early on, before swelling gets too bad, you might feel that the epididymis, which should be at the back, is actually rotated to the front. And as we mentioned, checking the lie of both testicles if they're both horizontal, that bell clapper anatomy makes torsion more likely on either side eventually. Oh, and prenatal torsion, if it happens before birth, presents differently. At birth, you'll see a firm, non-tender mass in the scrotum. It won't transilluminate, and the skin might seem stuck to it. Sadly, the testicle is usually non-viable by then.
Right. So you have a strong suspicion based on the history and exam. What are the next steps? Investigations.
Well, the absolute first step is that clinical assessment. History and careful examination looking for those key signs. The main investigation used to confirm or rule out torsion is a color Doppler ultrasound.
What does that show?
It uses sound waves to visualize the testicle and, crucially, to assess blood flow within it. In complete torsion, you'd expect to see little or no blood flow compared to the other side.
How reliable is it?
It's generally pretty good. High sensitivity and specificity in experienced hands, but, and this is a big but, it is operator dependent.
Yeah.
The quality of the scan matters. Plus, it might miss very early torsion before flow is completely cut off, or cases of intermittent torsion where it's temporarily untwisted, or even partial torsion. And sometimes, in cases of neonatal torsion, the findings can be ambiguous.
So not foolproof?
Not entirely. And you'll usually do a urinalysis too, mainly to help rule out epididymitis or a urinary tract infection.
What do the UK guidelines say about using ultrasound if you strongly suspect torsion?
This is really important. The guidelines, like those from BIUS, British Association of Urological Surgeons, are very clear. If the clinical picture, the history, and examination findings is highly suggestive of testicular torsion, you should not delay treatment by waiting for an ultrasound.
Why is that?
Because time is testicle. Any delay increases the risk of irreversible damage. If the clinical suspicion is high, the recommendation is immediate surgical exploration. Don't wait for the scan.
So straight to surgery.
In clear-cut cases, yes. Imaging might be more appropriate if the diagnosis is uncertain, if the presentation is atypical, or if it's been many hours since the pain started. But even then, it shouldn't cause significant delay, and you'd want senior urology input urgently.
Okay, so speed is paramount. What is the actual management once torsion is confirmed or highly suspected?
It's a surgical emergency requiring immediate intervention.
Right.
Sometimes, in the emergency department, an attempt might be made at manual detorsion. That's physically trying to untwist the testicle from the outside by rotating it outwards, like opening a book.
Does that work?
It can sometimes provide immediate relief if successful, but it's not definitive treatment. Even if manual detorsion seems to work, the patient still needs urgent surgery.
Why?
For two reasons. First, to confirm it's fully untwisted and assess the viability of the testicle. Second, and crucially, to perform an orchidopexy.
Orchidopexy.
That's where the surgeon surgically fixes the affected testicle, and usually the other one too, to the inside wall of the scrotum with sutures. This prevents it from ever twisting again.
Ah, because the underlying problem might affect both sides.
Exactly. That bell clapper anatomy is often bilateral. So you fix both to prevent future torsion on the contralateral side. The absolute rule is treat all acute testicular pain as torsion until proven otherwise. Get the urology or surgical team involved immediately.
What's the outlook then? What's the prognosis after torsion?
It almost entirely depends on the duration of torsion before blood flow is restored, how quickly treatment happens.
That time window again?
Yes. If surgery happens within about 6 hours of the pain starting, the salvage rate, the chance of saving the testicle is very high, around 90 to 100%.
That's good.
But if you get past 12 hours, the salvage rate drops dramatically, maybe down to 50% or less. And beyond 24 hours, it's often as low as 10% or even close to zero. The testicle is usually non-viable by then.
So that 6-hour window is absolutely critical.
Critical. Hence the mnemonic, 6-hour window, high win ratio.
6-hour window, high win ratio.
Yeah.
I like it. What happens if the testicle can't be saved?
Then an orchidectomy surgical removal of the non-viable testicle is performed during the same operation. The other testicle would still be fixed, orchidopexy.
And options after removal?
A testicular prosthesis, basically an artificial testicle, can be inserted later on, usually after about 6 months, for cosmetic reasons if the patient wants it. Also, in cases where the testicle is saved but there's concern about viability or future function, sometimes sperm banking, collecting, and freezing sperm might be considered during the initial surgery, if possible.
Then what about those cases of intermittent pain?
If someone has recurrent episodes highly suggestive of intermittent torsion, elective bilateral orchidopexy is usually recommended to prevent a full sustained torsion event. And just briefly, sometimes with chronic lower-grade torsion, you might get just a segment of the testicle becoming ischemic, not the whole thing. But yeah, late presentation is the biggest factor for poor outcome.
What are the main complications we worry about, apart from losing the testicle itself?
Well, the immediate risk is testicular ischemia leading to necrosis or infarction tissue death. If left untreated, this dead tissue can lead to atrophy, shrinkage, infection, abscess formation, and obviously cosmetic deformity.
And longer term?
Fertility is a major concern. Even if the torsion affects only one side, the inflammation and potential immune response can impair sperm production, spermatogenesis in the other, unaffected testicle too.
Really?
Yes, studies show impaired spermatogenesis in up to 50% of patients after unilateral torsion, and subfertility is found in maybe 36–39% of them long term.
That's significant.
It is, which again underscores why early intervention to save the affected testicle is so vital, not just for the testicle itself, but for future fertility. And of course, there's the risk of recurrence in the affected testicle if it wasn't properly fixed, or torsion occurring later in the contralateral testicle if that wasn't fixed prophylactically.
So wrapping this up, the message seems overwhelmingly clear. Sudden, severe testicular pain is a massive red flag. It needs immediate medical attention. No waiting, no hesitation.
Absolutely. Think torsion first. Act fast. It is a true surgical emergency where time lost equals tissue lost, potentially impacting fertility down the line.
That urgency just can't be stressed enough. Rapid diagnosis, rapid intervention, that's what preserves testicular health and future options.
Couldn't agree more. If you take one thing away, it's that, if in doubt, get it checked out urgently.
Fantastic. A really clear and crucial deep dive for those listening who want to cement this knowledge or revise other key topics, especially for the MSRA. Do check out passthemsra.com.
And there are great free resources available, too, at freemsra.com. Definitely worth a look.
Excellent. Well, that brings us to the end of this deep dive. Thanks for joining us.
Keep that knowledge sharp. Until next time.